Hi, Dr. Breyer. It's very impressive for your lectures, and from your presentation, I feel you are not only a doctor or surgeon, but you're persevering. You're trying to step by step to achieve stable, reliable results to make patients happy. So it's very impressive. And I would like to share personal experience a little on TRCL implantation, and also have several questions to discuss with you. Okay.
这一段我还用翻译吗？
翻译行不是也行 ？OK， 可以。OK， So actually, we implant TRCL and the help of image guidance system is very useful. We have cholesterol, so we feel it's very precise. But when if we don't have this, before we have this system, we buy manual to make marks, and so for example, but there's a problem we noted that if we want a TRCL, the axial, the astigmatism axis is at 100 degree, but sometimes the manufacturer can only provide 94, for example, degree at this axis. So during the surgery, we have to make a mark at 0 horizontal level, and then during the surgery we make another rotation, make a mark at 6 degree. So this is a 2-step. So to simplify the procedure, we took a 1-step TRCL implantation method. So we only make a mark at the target axis preoperative. And during surgery, we use viscoelastic to protect the epithelium cell. And okay, and we implant the TRCL and adjust to the target axis. So we don't need to make measurement intraoperatively. So I think this 1-step method may be more simple. But the most concerned problem for TRCL implantation, I think, is the wart. The wart, because there are only 4 sides are still available, but the patient's sucks to sucks distance is very different. So sometimes during the surgery, we need to make a rotation to adjust the ICL position and to get a good wart. For example, this is an ICL, not TRCL. I just show you. Now we usually use rescan to measure the wart height during surgery. You can see the wart height is higher than we expected. So we make an adjustment, make a rotation to rotate the ICL to a vertical axis. And what heat is appropriate. So this means that if we implant an ICL, this is very good, this is okay. But if we want to implant a TRCL, we cannot make any rotation. So that's my question for Dr. Breyer. So how many percentage of TRCL patients need to be cases need to be exchanged because of the improper ward or post-operative rotation, and how to avoid this problem? That's my question, Dr. Breyer. Can you hear me?
I think they have to reconnect us. I think if you stop sharing your screen, then it works.
Okay.
Because, yeah, okay, good. So first of all, I was happy to see the Callisto because 6 years ago, I was the one developing it with Zeiss. And my
really?
2 other doctors, the vitreoretinal surgeons, they are using it, in fact, for the implantation of toric IOLs. So I was happy to see it, you're using it as well, because I think it's really a very good tool. So I'm happy for you, you have this tool. Then the wall problem is very often discussed. The thing is, I started now 18 years ago to implant ICLs. So there is so much everyday experience with me and my assistants. So I don't have to exchange them anymore because it's just experience. But this is eminence and not evidence-based medicine. So that's not a good argument. I think the only way, if you really want to improve this as a doctor and as a scientist, and you want to be very precise, and you want to have a very steep learning curve, is this A-scan from Dan Reinstein. He adverts at many meetings where you can measure really the sulcus distance. So we help ourselves with we make 3 IOL master measurements, and the rest is simply routine, doing it now for 18 years. But routine and eminence-based medicine is never a good argument in medicine and in science. So if you ask me, yes, it can be done better than we are doing it. It can be done with an A-scan. So if you look in the internet, A-scan, ICL sizing, Dan Reinstein, I think it's called ARC scan, ARC scan, then this is an argument. On the other hand, we now also have the IPCL that comes from India and has different in-between sizes. It has not only 4 sizes, but has in-between sizes. So this might be helpful as well. And then I was very impressed by I've never seen that before, about how you rotated the ICL and how the wall changed. This was very impressive. Thank you very much.
Okay. Let me translate first. 他说他这个我们的 Castle 这 Castle 这就是这个术中导航的是他以前参与过这个发明就说这个研发的，原来给蔡司公司的，说非常好用。另外呢，就是如何避免这个就是这个就是说你换这个 ICL 大小不合适。他说他基本不换，因为他这个就需要经验大量的工作，大量的经验去这个探讨经验学习。另外呢，他建议还是要精确的测量这个沟到沟的距离这个长度，然后呢选择合适的这个晶体，这样就会减少这个不合适的这个情况再就是呢，他还推荐了几个什么这个 AS OCT 或什么其他这个检测测量的这个工具 那个另外呢，他觉得他说现在也不是只有4个长度的这个 ICL 了。那么他说是不是其他公司的我没听明白，
印度的
是不是
好像
其他公司的？印度是吧？它中间的又加了一个啊，就是说，好比说原来是121、126，它现在有121、123、126，什么中间的又加了有这种，所以呢，这样你选起来就比较好了，就不是高了就是低了，就不会出现这个情况。那个杨主任他还说的什么有补充的？
因为最后他就对您的那个术中根据那个就是拱高旋转的那个很赞赏，因为他可能我觉得，因为之前我跟就是欧洲的医生交流，感觉他们有的是喜欢放水平位，他们不喜欢斜的这样，所以他们可能就旋转的放的很少。
Yeah, I have another experience I want to share with you. I think it's you may interesting. Okay. So what's my method to avoid the exchange of TRCL? It's we correct the asymmetry by femtosecond laser to do a RK. If the patient's asymmetry is less than 2 diopters, we will choose use a femtosecond laser to correct the astigmatism and implant an RCL instead of TRCL. And for this kind of patients, we can freely to adjust the RCL's position and avoid the exchange or the improper wards. For example, this before surgery, they have 1.75 and 2.25 and after astigmatism. And we made the right eye, we made the astigmatism correction by femtosecond laser. And after surgery, the astigmatism is 0. And the left eye is less than 1 diopter. So after surgery, the patient's cornea is very clear and we implant an ICL. And also we can correct the astigmatism with for the asymmetrical astigmatism. So we can correct it with different lengths of the incision. So this is before surgery. After surgery, the astigmatism get corrected, and before surgery, the astigmatism, and after surgery is like this. So, so now for most of patients, if the patient's astigmatism is less than 2 diopters, we will choose a femtosecond laser correct the astigmatism. So that's my experience.
I think that's a very smart, interesting approach. I've never seen this before, but it makes sense. It's a good idea. I have 2 questions. Do you do your AKs perforating, or do you do them intrastromal? So we personally do them intrastromal because we don't want to have an epithelial invasion. We don't want to have a foreign body feeling. So we just do them intrastromal. That's question number 1. And question number 2 is how, because with this kind of correction, you always get a little bit of a hyperopic shift. So you do the AKs first, then how long do you wait before you do the measurements you use for the ICL implantation?
Okay, the first question is他第一个问题是说这个我们的这个就说这个方法挺有意思，但是他觉得这个刚才这个杨主任他说这个第一个是那个
他说的您那个做飞秒的那个是穿透的还是在基质内的？
对，他这第一个问题呢是基质内还是穿透的？ So we don't do intrastromal because intrastromal there's a less effectiveness. And also the diameter should be about 8 millimeter to approach the pupil area. We do a peripheral incision. A relaxing incision is the diameter is 8.7 millimeter and open the stroma. And that's what we do. And the second question is, there's for Chinese people, we have our own parameters to correct the astigmatism, and there's no over correction. We don't make over correction. It's almost zero. But now we are making summary and adjust, modify our the formula. But according to our results, it is satisfied.
So you do to get you right. You do the AKs during ICL surgery or short before? So it's one procedure more or less, or do you have a time gap?
We do laser correction, correct the astigmatism at the same time, and then we implant the ICL in simultaneously.
So another question would be, because of course we are not always perfectly right, we tell our patients like 1% might need touch-up surgery with LASIK or trans-PRK. What is your experience about this?
You mean that after ICL implantation, patients may need correction, the remaining astigmatism?
Yes, if you're not like absolutely perfect emetropia, I would say our more or less spoiled patients, if they're not perfectly emetropia, then I do after ICL implantation, but it's only 1%, not more, but 1%, I do touch-up LASIK or trans-PRK. So what is your experience with that?
I prefer to exchange the ICL.
Okay.
Exchange, yeah, correct, appropriate diopters power for a new ICL.
Interesting.
我刚才他的问题就是另外就是我们这个激光矫正散光是不是跟 ICL 一起做，还是分开做，或者怎么样？我们都是一起做的，而且这个散光矫正呢，不是矫正它角膜的散光，而是在角膜上矫正它圈眼的散光，那个轴向跟角膜的散光还有点差别。他觉着有时候如果他问的问题是，如果有时候你做了 ICL 还有一点残余的这个屈光不正啊，那他都是用那个 trans-PRK 或者是 LASIK 去解决。那么他做的很少，但是有这个情况。问我什么意见？我说我们是都置换这个 ICL， 换一个合适的，不在角膜再做这个手术啊。杨主任那边还有什么补充的？他那边
还有一些观众的问题，要问一下 Dr. Breyer. Okay, Dr. Breyer, there are several questions that raised from the audience. So number one is, when do you do the marking? So before or after you dilate the pupil? So what is your workflow? This is
the cyclotorsion control is fine when you have a dilated pupil. It still works.
回答就是说，即便我们散瞳之后呢，我们的这个对于这个眼球旋转的控制呢，它这个激光标记仍然是很好的，所以说不用担心这方面的问题。And so question number 2 is that would you please describe a little more detail about trans-PRK for the corneal marking?
And I must get back to the answer, because with trans-PRK, you are not allowed to have a wide pupil, but with IntelliXSL system, you are allowed to have a wide pupil. So maybe you be so kind and correct this. So IntelliXS, if you have a wide pupil, that's fine. The IntelliXS femtosecond laser from LensR and the system is able to do this. But with the Schwind laser, you need a natural pupil when you do the trans-PRK marking. So I think that's a correct answer.
It's 14 hours.
就是他稍微补充了一下，就是说我们在用 Interlexis 的这个 LensR， 然后它呢可以是在瞳孔比较大的时候，但如果是 TransPRK 的时候，还是应该在瞳孔比较小的时候进行标记。
我有个问题是，正好杨总你翻译一下算了。
哎，好的。
就是他这个用这个 TransPRK 或者是 LensR 去做这个标记的时候，只是做个标记，那么他这个收费，他说了可能贵一些，但是他收很多的费用吗？病人能愿意吗？
Okay, Dr. Breyer, there's a question from Professor Li. So that is, how much will you charge the patient if you're using LensR or TransPRK to mark the cornea? Would you charge more for the patient?
It's depending on our NHS patients. We can't charge more. Private patients, we can.
我们还是根据患者的他个体情况，如果是相当于是自费的或者这样的患者呢，可以适当的多收一点费用，是这样。
另外一个就是我想知道，他做那个ICL 的时候，他用不用这个就说粘痰剂啊？他是怎么用？是先打再植入再冲出来，还是先植入再打再怎么样？他是怎么做
？There's another question that is about your ICL implantation procedure. So generally, would you inject OVD first and then implant ICL and then OVD again? Or so is there OVD before ICL implantation? So what is your preferred procedure?
I started to inject Metocel, and I did this for many, many years. Just 2 years ago, I changed to OVD. I also tried to implant only with irrigation. That's possible too. But of course, it's more tricky if you implant under irrigation without OVD. It's possible. It's also a good method because that's how I implant all my IOLs. I never use an OVD. I just implant under irrigation. So I hope this answers the question. I started with methylcellulose, then did 2 years OVD. And sometimes I implant them just under irrigation if the eye is easy accessible. If I have deep anterior chamber, I implant just with irrigation.
Dr. Breyer 回答呢，就是说他主要也是有不同的情况，他最开始呢一直是会用这个甲酰这类的，然后呢后面也会用咱们常规的 OVD， 但是对于一些患者如果他比如说这个前方很深，然后呢配合很好，然后眼位很好的话，他也可以选择就是不使用粘痰剂，然后呢是在一个灌注的情况下，然后植入ICL晶体。